Hello everybody, it's good to be here. My name's John Lewis and I'm the consumer representative on this project team. I'd like to first of all acknowledge Dr. Kylie Vong, who's our fearless leader, and Kylie's just had a recent addition to the family and that's why she's not here, and I've got the honour of doing the presentation. Our aim in this project is to support GPs to work more effectively as shared care providers for cancer patients. Why? When it relates to equity, that care, shared care, should be, if it works well, should be more local, it should be accessible, and it should be more holistic in that the GP is aware of all the other patients' comorbidities as well as just the cancer. What we're trying to do is to address the knowledge gaps that create barriers to widespread uptake of follow-up colorectal cancer care in general practice. And this is important because, one, there's no real evidence that follow-up in tertiary care actually improves outcomes. In fact, there's a lot of evidence that colorectal care cancer follow-up in general practice compared to specialist tertiary care results in equivalent outcomes, and that's both for the medical aspects of cancer itself and also for the psychological factors that go along with it. Having said that though, we still need more knowledge on which patients are suitable for shared care, which patients are not, and what resources are needed to support that model. Now, why are we doing this? What's our driving force? You'll know that advances in treatment has increased the chances of people diagnosed with cancer living for 5 years or more. We also know that colorectal cancer is one of the most common cancers diagnosed in males and females. And when you look at the conventional model for follow-up care for colorectal cancer, it sees patients going back to the tertiary care centre for periodic review every 3 to 6 months. That model may have been fine up until now, but with growing numbers of cancer survivors, the approach is really not sustainable, and the data suggests that Australian cancer survivor numbers will soon outgrow the oncology workforce. So we really need to do something different. Our research is based around a decision support triage tool. That tool was developed at Prince of Wales Cancer Centre, and it has the potential to triage patients on their suitability for shared care. What we're trying to do is to improve the effectiveness of that tool in the selection of different patient scenarios that may be at low to intermediate risk of complications, and then be able to support them in shared care rather than being fully supported in tertiary care. The results of that will help us to further define the roles of cancer specialists and GPs, and it will help us to inform the development of supporting resources. Now, how are we going to do this? We're going to use a qualitative methodology with questionnaires for both patients and for structured interviews for both GPs and cancer specialists. We'll be identifying cancer specialists already from Prince of Wales and St George hospitals who are part of a multidisciplinary team. We'll be identifying GPs from the Central Sydney and Southeastern Sydney Primary Health Network, and the people who have experienced colorectal cancer will be identified by the specialists in Prince of Wales and St George hospitals. What we're going to do is conduct 2 sets of interviews, one for consumers and one for the GP specialists. We think that we'll reach data saturation by conducting interviews with 6 to 8 cancer specialists, 6 to 8 GPs, and 10 to 14 people who have experienced colorectal cancer. I might add there that we don't really have any results at this point because we're still at a relatively early stage in getting the ethics report and getting the ethics approval. What will the decision support triage tool do? It will identify scenarios of low to intermediate risk of complications and therefore ones that are suitable for shared care. And we've got some of those scenarios there. So if you don't have any of those complicating factors like oxaliplatin chemotherapy or bowel incontinence or a stoma, then you're probably a very good candidate for shared care. I might add, just in my own instance, as a bowel cancer survivor, I had or have all of those factors, but I have to admit that I find my GP absolutely essential for week-to-week management of my own condition. And what we're talking about here is there has to be some role for GPs, but the decision support tool will work out the extent to which control is at with the tertiary care shared provider or the GP or some combination of both. Scenarios and examples. Well, we've got a number of scenarios that reflect the full spectrum of cancer patients ranging from low risk to high risk. In that particular scenario there, we've got a man that's had chemotherapy, he's got a stoma, he's probably not a good candidate for shared care, but these are the kinds of things we're going to have the specialists and GPs discuss in the interviews that we'll be conducting. How we're going to do it is we're going to ask the specialists to obtain baseline demographics from participating cancer specialists, GPs and people with colorectal cancer. We're going to do in-depth structured interviews on the suitability of patient scenarios for shared care and the resources needed to do that. We're then going to go with a pretty standard qualitative methodology in that all our interviews will be recorded, professionally transcribed, and we'll use a grounded theory approach to identify themes, and we'll be using in vivo 10 to do that. We'll cross-check all of those findings with a person who's experienced colorectal cancer, a GP and a cancer specialist to make sure we've got triangulation and our coding is comprehensive. There'll also be some regular discussion between the research team to make sure we're testing it out. Our outcomes, the first outcome is really about identifying appropriate low-risk scenarios suitable for shared care, and this will contribute to an evidence base that improves the accuracy of a decision support tool. Secondly, this will help increase the uptake of shared care models that provide more accessible holistic care for persons experiencing colorectal cancer and help relieve the workload on specialist cancer services. So it ties in very well into the more people we can treat and manage in primary care, the more accessible the care is, the closer at home it is, and the more it fits in with the other issues that they've got in their life. So having said that, I'm pretty much finished. What we're looking to do is hopefully next time we might come back and we actually have some data for you, but we don't at the moment. So thanks very much for that.
Thanks, John. I'd probably make two comments on that. The first of all is that we know that in certain populations, particularly where we have languages spoken other than English, while tertiary care often requires interpreter services, we know that people often have quite a strong bond with the GP and their primary carer who may speak their language, and they're a great first point of care. So I think this is a really important piece to be doing at that, towards integrated care. And the second thing I'd mention as well is that your point about capacity in hospitals and things as well. We do have surveillance being managed on the tertiary care side and the secondary care side, which is, we do see higher waiting lists for certain procedures such as colonoscopy, for example, where surveillance is being managed in the hospital where it may ideally be managed actually more with primary practice. So hopefully we see more of this sort of work and a reduction in the outpatient clinic burden as well. As you say, the population numbers are growing to a point where we will outstrip the oncology staffing capacity as well at some point. Do you have an idea of what this work might look like when you move on to the next phase, whether it's a sort of a process that could be replicated in other areas or a model?
Definitely. I think that particularly if you're looking at southwestern Sydney local health district and you're looking at the population of GPs out there that do have either that reflect the community languages of the population out there, I think there's huge scope for it. And hopefully we can generalise this beyond colorectal cancer and beyond just this study in southeastern Sydney. I might add too, we've got Professor Mark Harris in the audience here, and Mark's the Professor of General Practice at UNSW and is a major driver behind this project as well.
Any other questions for John? Thank you very much.
Okay, thank you.